Hi, how's everyone doing? So I'm Seth Feder. I work at the University of Texas here in Austin at the new medical school. How many people here are from Austin? Okay, so a few of you, but most of you are not. So I'll give you some people who are not from Austin. I'll give you the background of the school and kind of put in context why are we interested in IoT? Why am I here talking about IoT? Because I can tell you I'm not a network engineer. I'm a technologist. But out of my league, when we start talking about 5G, I've learned a lot this morning and learned a lot from Monica just now. And I'll tell you that, I don't know if you saw my deck, but I'll have a couple examples of why we have kind of bimodal use cases of large bandwidth and then other use cases that do use very little bandwidth. So who are we? So you know you're in Austin. So UT Austin, obviously major tier 1 university, and it was sort of an oversight that we never had a medical school here. You know, Texas is served by several schools in Dallas and San Antonio and Galveston and Houston. But all of a sudden, like Central Texas exploded, and there's 3 million people living here now, and like, uh-oh, we don't have a medical school. So that, you know, the healthcare of this community has been taken care of very well by local delivery networks like Seton. People from Austin know Seton, St. David's. But all of a sudden, you know, you have 3 million people and there's a lack of medical education opportunities and professional development for physicians. So we corrected that 4 years ago. I was a resident and we all voted to raise our own taxes to pay for a medical school. So I didn't know at the time, but I voted myself a job. And we're supported by the community, the county, and it's a unique opportunity to really start from scratch and do things right from the beginning. So we don't have freedom to do anything we want. You know, we have partners and sponsors, so you know we have to kind of keep it real. But for the most part, the faculty are fantastic. They've been recruited from all over the country, and they've come here to kind of do it right this time. So we're starting a school from scratch. And on the right-hand chart, like our mantra is rethink everything. So I don't have time to go through all that, but I'll talk to you about how we're going to rethink clinical care and some examples of the technology to drive that. So, new medical school, you have to have new buildings. We have 3 of them on campus here. If you get a chance to drive up, just drive up Red River Street towards the stadium and you'll see these buildings. This is going to be the center of our outpatient clinical care. So we're not building a hospital. I know this session's called hospitals, but the hospitals, ooh, hot mic. Hospitals are taken care of by the local Seton Medical Center. They run the University Hospital. I'm going to talk to you about the outpatient.
Problem solved.
Outpatient center, which is that white building on the left. So it's 200,000 square feet, and that's going to be the focus of our clinical care. So how we're rethinking things. So then again, putting this in context, where does IoT fit? So today, you know, your patient experience, if you go see a doctor, it's very broken up. You make an appointment, you wait, you see somebody who triages you, a nurse, then you wait again, and the physician sees you, and then maybe he or she sends you for tests, and you come back, and then you need an x-ray, so you go get that, and you come back days or weeks later, and you see a pharmacist in the end. You know, this is very broken up, and is anyone happy with this kind of model? No. So we're rethinking this model. So this is what what we're aiming for, the sort of what we call patient-centric design. So when you come visit us in that building I showed you, you will see a whole team of people in one visit. And you may see a nurse, physician, physical therapist, pharmacist, psychiatrist, perhaps. You know, and a care plan will be developed just for you. And when you walk out of there, you'll have a plan of how you're going to get better, or how you're going to live with whatever. If it's a chronic problem, how can you go back to a quality of life that you can accept? So that our goal is minimize the number of times that they keep coming back for visits. So getting down to details. So we think that IoT is going to drive that strategy. And here, this is an actual floor plan of just one of the floors in that building. And it's a little overwhelming. There's lots of little rooms. So the ideas are when our patients come to see us, when they walk up to the check-in, they're going to be handed a tablet, an iPad or something. And they'll register and they'll keep that the tablet with them. And first thing it's going to do is show them how to get to their room. So we're building this building, believe it or not, with no waiting rooms. So it's a zero waiting room kind of building. You go direct from check-in right to your room. And these rooms are like 100 square feet, so it's big enough for you, your family, because people typically bring a family member along with them. So in the rooms, there's a couch and then an exam table and things like that. So to enable that wayfinding, we're putting in Bluetooth low energy beacons for our real-time location service, RTLS. I think you guys probably know what RTLS is. I mean, this is technology that's been around for a while. So we've chosen BLE because, number one, we want your phone or that tablet to be your badge. So if you're a staff member, you usually carry a phone with you. So why do I have to attach a little funky tag to your ID just for RTLS? It also enables that wayfinding application. And so the patient go right from registration into the room. Provider gets notified. As soon as you walk in the room, they get notified, hey, patient's in the room. And then the staff walks in, and this orchestration happens where you see multiple people. And RTLS is going to drive all that, because in the middle of our work area, there's like what I call the air traffic control display, which shows which patient's in which room, the status, who's in with them, what's next on their agenda for the day. So everyone's kind of coordinated. And that's all automated. So the staff will also have RTLS badge. Now at first, we may go, in the bottom right, there's a picture of a badge. We may put on their lanyard. In the future, I think we will enable their own cell phone to be their badge. These things are nice because they also have a button. So while you're in with the patient, you can push the button and you can initiate a new service. You can call for somebody, or you can, if you hold it for a long press, it could be an emergency situation. So as you can see, this whole patient experience that we envision would not really be possible without RTLS. So that's what happens like during the visit. And then afterwards, we're collecting all this data of how much time the patient's in the room before they're being seen, how much time the staff are spending with patients versus charting or any other kind of activity. So we can go back retrospectively and get these kind of charts where, where are the bottlenecks? Are there delays? Why? And we can do basically increase the efficiency of the whole experience by looking at this data. So in the future, so this is great, this is efficiency, but what about like real-time analytics? And that's actually one of the things I'll talk about at the end, but this is one of our goals, is to actually improve the experience while it's happening. So if the patient's been waiting more than 3 minutes, we should get an alert, and someone can go interrupt that experience and make sure it goes better. So we're going to extend IoT to the patient's home, not just in this building. So like I said, the idea is like not to have you come back. Well, how are we going to follow you if we never see you again? So we want to monitor their response, because you can't improve what you can't measure. So we'll be using devices that measure vital signs, but also there's a new field, it's called patient-reported outcomes, or PROs, where patients are doing surveys to tell us about their pain or their activity, and these are done usually over a phone or a computer through a web browser. We're going to be enabling telemedicine visits too, so we want the physicians to be able to speak directly to patients remotely rather than have you come all the way back downtown for an appointment. And again, the idea is to stay connected and measure our effectiveness. So opportunities to work together. So we know that Wi-Fi and Bluetooth are notoriously unreliable, especially in the consumer's hands. I can't imagine giving someone a Bluetooth, connected watch and saying, hey, please pair this with your phone, and when you go home, connect it to your internet connection, because I can't rely on that. So these devices should, on their own, connect back directly to us. And we don't need a lot of bandwidth. If these vital signs are very discrete, small amounts of information. I did mention telemedicine, so that's the other example where we do need a lot of bandwidth. If we're doing voice and video. And again, we can't. A lot of our patients, our mission is to treat the underinsured or uninsured patients, and many of them don't have internet at home. Interestingly enough, 90% of that population has a smartphone, but they may not have internet at home. So we can't rely on their Wi-Fi connection to connect them. So that's why we want these devices that can connect back to us directly. And then we're looking at real-time analytics, if you want to call it artificial intelligence, but ways that we can make decisions live as the data is coming in. So I mentioned before, for service recovery, if someone's while they're having a visit, we can intercept any kind of bad experience. And we can look for health trends that are negative once they go home before the patient notices. So that is in a nutshell from, I don't call me a consumer of IoT, but that's what we've been planning. And thanks for your attention. I look forward to learning more from you all too. Do we get questions now?
Are there any questions from the audience? Yes.
Mr. Clardy?
Good to see you again.
You too.
Two-part question. First is, what's your view on liability from real-time monitoring of patients at home? The second is, in the evolved future of multi-clinic deployment, where does public cloud or private cloud come into the picture?
Yeah, thanks. So when it comes to your first question about sort of liability of monitoring someone remotely, so if it's a life-threatening or life-sustaining technology, this is not meant for that. That's their dedicated EKG monitoring equipment for that. This is meant to be what I would call low-intensity type of monitoring, like things that don't need an immediate response. But there are dedicated devices that do home monitoring for cardiac patients. So we're all in on the cloud. So the University of Texas has agreements with Amazon and Microsoft Azure. We have BAAs in place with them, which means they've agreed to security controls and risk sharing with us on HIPAA violations. So I think the cloud companies have really stepped up. I think 10 years ago, Amazon, not 10 years ago, let's say 7 years ago, Amazon wouldn't have signed a BAA. But now they're happy to do that and kind of share the risk.
Question.
Hi.
You mentioned real-time analytics. Wouldn't it be possible to do a lot of the analytics on personal devices that exist already in the home and only signal in case of aberrant activities, thereby preserving the quality of the HIPAA requirements? Yeah,
that's a good point. We can certainly do that. So I'm not worried about, I think there are plenty of ways to securely transmit data. So I'm not too worried about that. But you're right, I think a lot of when it comes to medicine, a lot of it comes down to someone has to make a judgment call. And we don't want patients to have to judge, well, is this, am I in trouble or not? Like, I need to figure it out. We want them to be able to rely on us to help them with that decision.
They may not be that cognizant at that point to be able to make that decision.
Yeah, that's right. That's a good question. Hi. 1 minute.
Okay, one question over there.
Yeah, you mentioned that the devices in patient's home, they don't all have Wi-Fi connection, so you want a direct connection. What were you talking about with a direct connection? How would you do that?
So over, like a 5G network, over a cellular type wireless connection. So I don't want to rely on an access point that's running in their house somewhere. Yeah. One more question?
For the remote visit, understand that the medical data has got to go over a HIPAA compliant network, but the video, would it not be FaceTime or?
Yeah.
Okay.
Yeah. I think actually some of our faculty have used FaceTime, and I think we're going to try all these things and see what we can prove are secure and reliable.
Okay,
Thanks.
thank you so much, Seth.